behalf of Indian Association for Bronchology, invite you and welcome you to the Module 8 of the EBUS certification course by IAB. As we all know that we have 10 modules of EBUS, which are online webinars, which for certification you have to attend at least 8 out of 10 for at least 90% of the time. Following which we'll have hands-on workshop in 4 zones of the country as we had with the thoracoscopy workshops. And this module 8 promises to be even bigger with all the star-studded faculty, and it is going to be on Radial EBUS. I would like to thank our academic partners, Olympus and Mankind, specifically Mr. Nitin, for handling this in the background. Now, before I hand over to our faculty, I would extend my welcome as part of the NAPCON committee. Can you put up the NAPCON slide, please? Our National Conference of Chest Physicians, NAPCON, is happening in Pune from 23rd to 26th of January. I extend my warm welcome to all of you for this academic feast. I'm sure you'll see full halls and you'll definitely learn a lot. So for all the PGs and all the consultants, please join us for NAPCON Pune. Now, let's start with our IAB module. Can I have the slide? Yeah. It is my pleasure and my privilege to introduce the captain of the ship today, Dr. Ujjwal Parag. Sir needs no introduction. He has been practicing for more than 27 years. He is a senior consultant and Department of Pulmonary Respiratory Medicine and Interventional Pulmonology in Sir Gangaram Hospital, New Delhi. He is a fellow of NCCP, TES, and Joint Secretary of Thoracic Endoscopic Society. His areas of interest are interventional pulmonology and interstitial lung diseases. Sir, I hand over the mic to you.
Thank you, Mehul. At the outset, I would like to thank the IAB as a whole and Dr. Amita Nene in person for inviting me over here and doing a wonderful job of educating people all across the country and globe. Uh, Today, we are be talking about radial EBUS. Radial EBUS is the original EBUS. It came first before the linear EBUS, but because of the versatility and the easy usability of linear EBUS has always become a very hot favorite. But radial EBUS slowly and slowly is now becoming important because now instead of just focusing on the mediastinum, our focus is moving towards diagnosing the distal pulmonary nodules as well, so that our diagnostic workup is complete in a patient. And radial EBUS definitely helps in making a diagnosis and helping us moving ahead in the management of a patient. So today we have got a very good faculty. We have an excellent speaker and a panelist. So before I introduce our panel, I would first like to introduce Dr. Nagarjuna, who is going to be speaking about radial EBUS. He needs no introduction. He has been a star for last many years, and he has taken IP with the help of new technology to the next level in the country. He has been first in a lot of things, and he has been instrumental in introducing a lot of new technologies into IP in the country. He's presently a clinical director in the clinical and interventional pulmonology department of Yashoda Hospital in Hyderabad. He has multiple publications, read person, and he has a very keen interest in not only taking IP to the next level as a clinician, but as an academician also. He has been organizing wonderful workshop and conferences in the past couple of years and educating everybody in the country. His areas of interest has been interventional pulmonology, severe asthma, ILD, and COPD. As I've told you, he has been first to introduce bronchoscopic transpulmonary nodule access. He has been instrumental in being first to use bronchial thermal vapor ablation technology, biodegradable airway stents, and navigational bronchoscopy in the country. He has keen interest in lung nodule, and therefore he has introduced the first lung nodule clinic in the country. So I welcome Dr. Nagarjuna to please deliver his talk.
Thank you so much, sir, for the kind introduction. So, as I share my screen, I should thank the IAB, Amita madam, my dear friend Mehul, and everybody for conceptualizing this series of educative events. So this is the first one on radial EBUS. The last seven have been on linear EBUS. So I will talk about the steps of radial EBUS, how to do. I will not bore you with articles. I will only talk about the practical aspects of how we do radial EBUS. The only unfortunate thing is that I have only 25 minutes to talk about a thing which is so vast. But then I will try to do justice to what I've been given. So radial EBUS, EBUS stands for endobronchial ultrasound. So broadly, you have linear EBUS and radial EBUS. Linear is for the mediastinum and radial is for the peripheral lung lesions, not necessarily the nodule. It can be used for any peripheral lung lesion. So as we go about, let us start with a case and then we will go on as to how to go about. So this was a 55-year-old diabetic, so smoker, who presented with weight loss and a CT was done which showed a nodule in the apex of the right lung. So this is a very common scenario. You find a lot of peripheral lung lesions. So how do we go about it? So this is something which is very important before we dwell into radial EBUS. The first thing is, do we actually have to do radial EBUS or is a CT gated biopsy sufficient for everybody? So this is the first decision we have to take, CT gated versus bronchoscopic biopsy. As we all know, CT gated biopsy has been there for quite some time. The yield goes up to 90% or sometimes even better. But the only problem with CT gated biopsy or percutaneous biopsy is the fact that it has a very high complication rate. And this is where the bronchoscopic technologies have an advantage. So, broadly speaking, how does a bronchoscopic approach to peripheral lung lesion score over a CT gated biopsy? Is one, lesser pneumothorax, 20% versus 1 to 2%, better ability to control a bleed. If there is a bleed which happens, your bronchoscope is inside, you can control the bleed better. Third, very important in our country is the fact that you can do a simultaneous BAL. You have a lot of infective nodules, infective lesions in our country. Fourth, again, simultaneous medicinal staging. In the last couple of years, we have completely switched over to diagnosis and staging in the same instance because we have rapid onset evaluation. And last, there is a lesser chance of needle tract metastasis. I think this is broadly about the advantages of bronchoscopic sampling over a CT-gated biopsy. So in the index case, as is the norm, because CT-gated biopsy is available across the country. A CT-gated biopsy was done even before the patient came to us. Unfortunately, it was inconclusive. So he was referred to us for the intent of a bronchoscopic sampling, and that is what we have done. So when we talk about bronchoscopic approach to peripheral lung lesion, radial EBUS is the forms the background on which everything else is added. So it is the base. The first publication was in 2002. So this was by Professor Hirth. And when radial EBUS was launched, the only thing which was available was a fluoroscopy. So they had said that it was as good as a fluoroscopy. But then this 2002 marks the landmark year, the watershed zone in the field of peripheral bronchoscopy. So before radial EBUS, the peripheral bronchoscopy was having a very bad outcomes, that the diagnostic yield was only 30%. But since radial EBUS has come, so it helps us visualize the nodule so that you are in a better position to diagnose. So the yield has gone up to 60 to 70%, but that is still less than 90%. So what has happened over the years is radial EBUS has been topped up by multiple other innovations, and because of which the yield now has come to 90%, which is on par with a CT-guided biopsy. So, but today in this lecture, I will not talk about radial EBUS. I will not talk about the add-ons to radial EBUS, though I might talk about a few of them. So, since 2002, there has been a flood of articles and there are multiple meta-analysis. So, this is in 2017. There is another one in 2024. But irrespective of what meta-analysis it is, the diagnostic yield of radial EBUS is 70%. If you use only radial EBUS, your yield is going to be anywhere between 65 to 75%. The complications are obviously much lesser, only 2%. There are several predictors of higher diagnostic yield. I will not talk about all these things, but some of the important things are the size and the relation of the nodule with the airway. If you have a direct airway going to the nodule, you will have a higher diagnostic yield. That is called as a CT bronchus sign. There is another analysis which looked at how addition of things have improved the yield. So this is published in this year only. If you look here, so radial EBUS with a navigation with a cone beam CT now is giving a yield of 85 to 90%. So radial EBUS alone 70%, radial EBUS with the newer technologies 85 to 90%. This is what you should understand. Now that is just about the data. Now coming to the practical aspects. So before we go into how to do, this is something you have to understand. You should understand your equipment. Now in India, you have two companies which market radial EBUS. One is the Olympus, second is the Fuji. So Olympus has been in the market for quite some time. I think it's been more than a decade since we have the original studies, everything was Olympus. Now, Fuji has recently come up with its radial EBUS over the last couple of years. Pentax still doesn't have a radial EBUS of its own. So, Olympus versus Fuji. Now, I will briefly talk about the Olympus because we have been using it, and this is on which most of the studies have been performed. So, you have an ultrasound processor, you have a probe driving unit to which the radial EBUS probe has to be attached. Then you have a radial EBUS probe, this one, and a guide sheath kit. I will talk about the guide sheath kit. Then this is how it is. So everything goes through the channel of a flexible bronchoscope. So the guide sheath, the radial EBUS probe, everything goes through the working channel of a flexible bronchoscope. Now coming to the processors, we will not go into the specifications of the processors, but what you have to understand is that the Olympus linear and radial EBUS processors are the same. The same processor has two. This one connects the radial EBUS. This is for the linear EBUS. So you have EU 1, 2, and 3. ME1 will be phased out very soon. Whereas Fuji has a separate radial EBUS processor called as the SP900. Now coming to the probes. Again, Olympus has two radial EBUS probes. These thinner and the thicker. This is what I would call it, but 17S for those who want to use the technical term, 17S and 20R. So 17S has a 1.4 mm diameter, 20R has a 1.7 mm diameter. Both have 20 megahertz frequency. This is different from linear EBUS where you have frequencies varying from 5 to 15. So radial EBUS has a higher frequency, so lesser depth of penetration. So all the radial EBUS probes have 20 megahertz. So each radial EBUS probe has a compatible guide sheath kit. So 17S is compatible with 401, 20R with 403. I will talk about it. So this is a slide which compares the Olympus with the Fuji radial EBUS probes. If you can see, most things are same. So the radial EBUS probe revolves 360 degrees on itself, and you will be able to see the ultrasound image of the lung parenchyma which is surrounding the radial EBUS probe. So this is a 360-degree view. That is what is important. All of them have 20 megahertz frequency, which you can't change. The diameters are different. So 17S is 1.4, 1.8. 20R is 1.7 to 2, and Fuji PB2020 is also similar, is equivalent to a thicker radial EBUS probe. So for all of them, the probe has to come in contact with the bronchus or the alveolus. Only then you will be able to see it. If it is in the center, you will get artifacts. Now coming to the guide sheath kit, this is again something you have to understand. You have to know how to set it up. So you have a guide sheath. The guide sheath kit comes with three parts: the guide sheath, the forceps, and the brush. Okay, these three things are in the guide sheath kit and also has stoppers. Again, there are two guide sheath kits. The older numbers were 201 and 203, but now it is called 401 and 403. The smaller guide sheath is for the smaller probe. The larger guide sheath is for the larger probe. The only thing is that you should know the compatible scopes. I will talk about that also. You also have certain stoppers. This is something which you have to understand. The beginners have to understand. You have two types of stoppers: the ultrasound probe stopper and the stoppers for the other equipment. So this is how the guide sheath kit has to be set. So through the guide sheath, you pass the brush, you pass the forceps, you pass the red libus probe. And if you have this bending device, that is there, but in India it is not available. So this part is not required for us. So each of these accessory has to be fixed. That is very important. So very small video I would play. This is again from the Olympus. So this is the guide sheath. So the guide sheath itself has a stopper. So that is used to fix the guide sheath onto the bronchoscope. Okay. Now through the guide sheath, you pass the accessory and fix the accessory such that the tip of the accessory just protrudes out of the guide sheath. So this is the stopper again. So for the brush, for the forceps, for the radial EBUS probe, you have stoppers. So you load the stopper onto the accessory. So now the stopper is being loaded. Once you load it, then you pass the accessory through the guide sheet. So that also will be shown. I'll just take a couple of seconds for this thing and then we'll go on to the radial procedure per se. Now this brush is introduced into the guide sheath. Okay, so once you introduce into the guide sheath, you fix it such that the tip of the brush protrudes just out of the guide sheath. So there you fix the stopper. Similarly, you do the same thing for the forceps. You do the same thing for the radial EBUS also. So this is for the biopsy forceps. You do the same thing. So I will not play it again because of lack of time. But then once the setup is done, the basic concept is that once you have the guide sheath in position, you remove the red EBUS probe and put the forceps and the brush. So you would not know how much to insert if you are not pre-measured the distance to which it has to go inside. So this thing takes around 5 minutes and it has to be done before you do the procedure. So now that is about the equipment. So I'm already 5 to 10 minutes down into the lecture. So now this is very important to understand that whenever you sample a peripheral lung lesion or a nodule, that is not just radial EBUS. So you have basically, I always say 5 steps. First is you decide whether to biopsy and whether to do a bronchoscopic biopsy or not. Two, if you choose to do a bronchoscopic sampling, you have to reach the place, reach the nodule. Then you have to see the nodule, that is to see, visualize the nodule that you are there. Then you biopsy the nodule, then you analyze the nodule. This is the 5 steps. Now for each of these steps, you have technologies which will help you. For example, to navigate to the nodule, you have a navigational software and you use thinner scopes. The adult scope, conventional adult scope won't go deep into the lung parenchyma, so use thin scopes. Now to see the nodule, this is where radial EBUS comes in. So radial EBUS basically helps us only in one step, that is to see the target. This is very important. Also, you can use fluoroscopy or augmented fluoroscopy. And you also have cone beam CT now. So you have a lot of things. Then you have to sample. So as I've shown, you have a forceps, or you can also use a cryo. And then you can add rapid onset evaluation to the whole thing so that you can analyze it on the spot. So this is how the whole flow happens for every case. This is the 5 steps. Now for the index case, step 1 is over. You wanted to do a bronchoscopic sampling. Now, how do we reach that apical nodule? Is it easy? How do we, you will get lost in the maze. So now, so before we do radial EBUS, this is what I said. You have to decide whether to biopsy or not and whether to do CT guided or whether bronchoscopic biopsy. Now to reach the nodule, you have to navigate yourself, which means navigate your bronchoscope on the probe to the target. So now there are several ways to do the navigation. The simplest is called the manual navigation, which means you sit with a CT scan, you chart out each branching, and then you figure out where to go. This is also feasible, but you also can take the help of technologies. In India, we have three virtual bronchoscopic navigation by two companies, by Broncos and the Fuji Synapse. You have Archimedes transparenchymal nodal access again by the Broncos. You have cone beam CT of both Philips and Siemens. So all of these are there in India at this point of time, and we have access to all of them. So we're in a sense lucky that we have access to most of these. This is the navigation for the lung point and the Fuji. This is how a manual mapping is done, but it requires a good cerebral cortex and it needs a lot of time. So in the index case, because we don't use our cerebral cortices too much, so we take the help of this artificial intelligence, and the lung point gave us a path. So we know where we have to go. So this is the path we have to take. So that is anyways not the intent of my talk. So now the thing is radial EBUS. How do we do radial EBUS? So how do we see it? How do we visualize? This is what I'll be talking about. So now in the index case, you know that you have reached there. Now radial EBUS comes in seeing the nodule. So again, before we start talk about it, what are the various ways in which you can see a nodule? So broadly, there are four. One is a radial EBUS. Second is a conventional fluoroscope. Third is an augmented fluoroscope. Fourth is a cone beam CT. So these are the four ways in which you can see the nodule. So radial EBUS is the only technology where radiation is not used. Okay, but the disadvantage of radial EBUS is that once you see the nodule, when you have to take a biopsy, you're not seeing it anymore. So it is not real time. So real time is not there for radial EBUS. So if you combine radial EBUS with a fluoroscopy or radial EBUS with augmented fluoro or radial EBUS with CBCT, so you would be also seeing the nodule and visualizing real time when you're taking a biopsy. So that is how you combine technologies to get a better yield. Now, broadly speaking, the technique of radial EBUS, there are two techniques. One is called the guide sheath technique. Second is called without guide sheath technique. Now, for both of these techniques, the prerequisites are one, you have to map your path. You have to give some sort of sedation. You don't want a person who's coughing. So you can do under deep sedation, you can do under general anesthesia, whatever way you are comfortable, but you want a comfortable patient. It requires two people, one handling the scope, second handling the probe and accessories. You have to prepare the guide sheath kit as I have said, and you have to choose your bronchoscope wisely. Generally, we use a thin scope or an ultra thin scope for peripheral lung lesions. Now, once you are reached the target, I think this I will show a video, then it will be easier for us to understand. Uh, when we want to use the guide sheath, the radial EBUS is kept inside the guide sheath. Okay, and the guide sheath is passed into the bronchoscope to the target. So this is how it is. So the guide sheath and the radial EBUS probe will be there. Once you identify the tumor, the radial EBUS probe is withdrawn. The guide sheath will be left in place, and through the guide sheath, the brush and the forceps would be passed, and then sampling will happen. So this is a video again showing the same. Once you find the target here on the radial EBUS probe, you fix the guide sheath, you fix it with the stopper, then the radial EBUS comes out, and then the brush goes in, and then the forceps also will go in. So this is how a radial EBUS with a guide sheath is performed. Okay. So again, this is another video. This is again from Olympus. So this is how it is. The nodule is deep inside. If you use a standard scope, you won't be able to reach there. So use a thin or an ultra thin scope. You can see the guide sheath and the radial EBUS probe. You first search for the nodule. Once you reach the nodule, okay, so you reach the nodule there. That is when you fix the guide sheath onto the bronchoscope. Okay, and now the probe went outside and the brush has come. So you do the brush, you do multiple jabs with the brush, take it out and then smear it. Then you get the forceps, open, close, and then take a biopsy out. So the guide sheath will remain there so that you know that your accessories are going to the target where you want it to go. So this is the conventional technique called as the guide sheath technique. So it has its own advantages and disadvantages. Advantages mean the two advantages. One, it ensures that all your accessories are going to the correct place. Second, it decreases the chance of blood from spilling over. But it also has certain drawbacks. So the guide sheath will enable only a very small biopsy. If it's a 2 mm guide sheath, you will not get more than 1.5 mm pieces. That is the thing. Second, you cannot use a guide sheath with an ultra thin scope. Many times we use an ultra thin scope to go deep into the airways, then you cannot use a guide sheath kit. In fact, now there are a lot of studies which compared guide sheath versus no guide sheath, and it has been shown that adding a guide sheath will not actually increase the diagnostic yield. In fact, some studies have shown the other way around also. So using a guide sheath is not compulsory. Now we have to understand which scope is compatible with which radial EBUS and which guide sheath. So broadly speaking, you have four types of scopes: the conventional therapeutic scope, the thin scope, ultra thin scope, and the pediatric scope. So pediatric scope has a working channel of 1.2 mm, which means none of the radial EBUS probes would go. So with the ultra thin scope, which has the channel of 1.7, you can use radial EBUS, but without a guide sheath. The 17S would go in, but a guide sheath won't go. Now, if you use a thin scope, you can use a guide sheath kit with a thinner 17S with a K201 will go, or 20R will go without a guide sheath. Okay, so the thin is what we normally use. Ultra thin also we use. But if you want to use a standard adult therapeutic scope, the both guide sheath kits can be passed through. This is something which you have to understand. I think the more you use it, the easier it would be. Hmm? Now, when we want to do without guide sheath, how is it possible? So once you remove the radial bus, you don't know where your accessories are going. So this is something which you have to understand. It is not essential, but it is important to know. So once you are, if you're not using a guide sheath, through the working channel of the bronchoscope, you pass the radial bus probe, you identify the target. Then you do two things. You do a simultaneous fluoroscopy or an augmented fluoro and mark your target or mark your probe on the fluoroscope. So with this, what happens is next time when you pass a brush or a forceps, you know that you have to reach that target on the fluoroscope. That is one way of doing it. Second way of doing it is you exactly memorize to what depth you put the radial bus, to in which segment you went, in which subsegment you went, and you pass the biopsy brush or the forceps to exactly the same depth into that particular segment so that you know that you're sampling that precise area. Okay, this is how without guide sheath. In fact, now most of the times we do not use guide sheath. We combine radial EBUS with a fluoroscope or a combined radial EBUS with an augmented fluoroscope. And then we don't do guide sheath because we get very small pieces through guide sheath. We use guide sheath when we feel that the bleeding risk is higher or the lesion is pretty big, and then you can pass a larger guide sheath and then do. So that is about the technique per se. Then understanding the radial EBUS image. This is also important. I'll spend a couple of minutes on this thing. So this needs some understanding. It takes some time to get oriented to the how an lung looks on an ultrasound. So normal lung will have what we call as a snowstorm appearance. The central black circle is your radial EBUS probe. Everything around it is the lung around it. So normally you have a white zone, that is the normal aerated lung parenchyma, and then it becomes black. So when you have a ground glass nodule, you have a blizzard sign, which means that the white zone is increased in diameter. Then you also have what we call as a mixed blizzard sign in a subsolid nodule, where you have hypo and hyperechoic areas, and this is how a mixed blizzard sign or a subsolid nodule looks. Solid nodule would look like this. So you have an area of black hypoechoic structure surrounded by a hyperechoic line, which is the rim of the lung which surrounds the nodule. And again, you can have three relations. So this is called as the nodule airway relation or the probe target relation. So where your probe is in relation with the target, if your probe is in the center, you will get a concentric image. If your probe is on the side like this, you will get an eccentric or adjacent image. This is extremely important because your target is to get a concentric image. If you get a concentric image, your diagnostic yield is 80 to 90%. But if you get an eccentric image, then your yield is going to be 50% or lesser. This is very important. Your target is to get a concentric image. Now, beyond this thing, there are certain other things which you have to learn to recognize. One is the margin. Second is the air bronchogram. The linear hyperechoic arcs are called as the air bronchogram. Then you also look at heterogeneity. You can look at the vessels. You can look at the dark hypoechoic areas in the center or the vessels. They can pulsate sometimes. If you have a big vessel, you be careful. It can lead to bleeding. So these are all several radial EBUS features which are being described. Similar to how linear EBUS you have characteristics, now you have radial EBUS characteristics. And this is one beautiful study from Malaysia which has shown that if you have a radial EBUS showing an air bronchogram, the chance that it is tubercular will be higher. But it is just a predictor. It is not that it would obviate the need for a biopsy. Now, in the index case, so using a radial EBUS probe, we could put the radial EBUS, and this is what image we got. You got a sort of concentric image. So once you get a concentric image, then you do the sampling. So this is another example of a 71-year-old male who had a nodule in the left apex. So the first case was the right apex. This is the left apex. So this is a speculated margin. So again, a CT-guided biopsy was done. It was inconclusive. Then they were referred to us. So this was the nodule characteristics. So speculated margin. So we wanted to do the procedure. Again, VBN was used. Thin scope was used. Along with that, a fluoroscopy was used, and we got a radial EBUS like this. If you see the radial EBUS, you can see it's an ill-defined margin. You find a lot of linear arcs, that is the air bronchograms which we are seeing, and there are no blood vessels there. So this turned out to be tuberculosis on BAL. Biopsy didn't show granuloma, but it showed OP, but nevertheless it was tuberculosis. So this is how a radial EBUS characteristics of the nodule may sometimes help to predict what it is. If you find a lot of air bronchograms, you would want to do a BAL also. Now, once you identified the lesion, you sample the lesion. Again, there are several ways you can sample the lesion. Okay, so I have talked about brush, I have talked about biopsy, but there are several other things. You can do a BAL, you can do a guide sheath flush, you can do a device channel flush. This is three ways to get a liquid out of it. Then you also have cryobiopsy now, and now the most important, the latest is the peripheral TBNA. Olympus is coming up with what we call as the peri-view flex TBNA needles. Because of lack of time, I won't talk about it. Broncos also has one peripheral TBNA needle. You have a lot of peripheral TBNA needles. So now, once you see a nodule, there are four things you can do. You can do breast cytology, you can do BAL, you can do biopsy either by forceps or cryo, and you can do a peripheral TBNA. So four things can be done. So this is one very old study which has shown that adding each of these will have a different diagnostic yield in diagnosing peripheral lung lesions. Because of lack of time, I won't go through it. But this is again very important. The landmark article again from the same Malaysian team, which has shown that if you find an eccentric image like this, forceps is not good. So there you have two options. You can either do a cryobiopsy or you can do a peripheral TBNA. But if you find a concentric lesion like this, forceps is as good as cryo. So again, this is how our algorithm has changed. So when you use a thin scope, radial EBUS, concentric image, you do forceps or cryo. Eccentric image, no forceps, only cryo. This is how we do. Now, I think this I would skip for lack of time. And in the index case, what we did, it was a concentric lesion. So we did BAL and forceps. So forceps showed granulomatous inflammation. BAL was negative. So it was necrotizing granulomas, but it was diagnosed as tuberculosis, and the patient improved on ATT. So that's the first. Again, now last point is once you take a biopsy, so adding rapid onset evaluation. Now there is a lot of papers which have shown that adding rapid onset evaluation would help in increasing the yield, would improve the operator's comfort. Three, it would help in triaging the sample. And four, it would also help if you have to do a simultaneous mediastinal staging. So there are again several types of rows: pathologist rows, pulmonology rows, tele rows, and WhatsApp rows. There are four types of rows which have been described. I will not talk about all these things, but this is there. Now you also have artificial intelligence coming in rows. That's a whole area, chapter by itself. Now one RCT where people were randomized to rows, no rows. The diagnostic yield was better in the rows group. Again, even the biopsy can be assessed by rows, stamp cytology. So a lot of things can be done. So that is in brief about how we do radial EBUS. So I think one last case and I will wind up. 54-year-old male referred for again evaluation for a peripheral lung lesion. BAL was showing high galactomannan, started on antifungals empirically. PET done, AVID. So this was the bronchus. This is the nodule. You can see the bronchus sign. If you have a feeding bronchus sign, then your confidence is much higher. Step one is, okay, you wanted to do a bronchoscopic biopsy. Step two is to navigate to the lesion, either manual mapping or take the help of a navigational software. So in this case, you can see it is in the apical segment of the right lower lobe. Step three is to put a radial EBUS and see here you got a eccentric image on radial EBUS. Step 4 is to biopsy. When you get an eccentric image, your forceps will not be diagnostic, and that is what happened. So we had to do a imprint cytology, a cryobiopsy. And step 5, Rose gave us diagnosis of adenocarcinoma. Now, same time, because it is adeno, we did simultaneous staging linear EBUS that was inconclusive, and the patient was sent for surgery. To summarize our approach to lung nodule, so bronchoscopic approach is chosen in the nodules which are not touching the pleura. But touching the pleura, we also do CT-guided biopsy. Radial EBUS is the backbone for all sampling. All cases are performed with a thin, ultra-thin scope. In our center, we always use ROSE. If it is small nodule, we add a navigational bronchoscopy or a CBCT. If it's an eccentric image, we add a cryobiopsy. So this is in brief about how we use radial EBUS and add technologies to the radial EBUS. So again, we have to understand that radial EBUS and CT-guided biopsy are complementary. I'm not telling radial EBUS is the only thing. Each has its own advantages, but you have to choose your accessories wisely. And this is a new era as far as the peripheral bronchoscopy is concerned. And as Madam has said, this we have started the lung nodule clinics this year. And with this, I would thank everyone for patiently listening. I think I've overshot by a couple of minutes. I'm very sorry, sir. Thank you so much.
Thank you, Dr. Nagarjuna, for a excellent talk on radial EBUS. But we know that it's a very long topic, and you have been kind enough to cover almost all the aspects of the intricacies of radial EBUS and what newer technologies can do and help in increasing our yield. With this, I would like to open up the panel discussion. And in our panel discussion, we have got very eminent and young and vibrant pulmonologists. First of all, I'd like to introduce Dr. Samir Verde. He is a director in the Department of Pulmonology, Intervention, Pulmonology and Lung Transplant in Mumbai. And he has the multiple publications, and he is a keen person to learn and to make people learn about what is interventional pulmonology. Welcome, Dr. Samir.
Thank you so much, Dr.
Sec-
Ujjwal sir.
Second on our panel is Dr. Vijay Kumar. Basically, he is also from Hyderabad, and he is a senior consultant interventional pulmonologist who has interest in basically interventional pulmonology, thoracoscopy, and end-stage lung disease, ILD, and ARDS. He is a very uh, famous person, a very good friend, and I welcome Dr. Vijay on this panel.
Thank you, Ujjwal.
Number 3 is our young pulmonologist from Delhi, Dr. Ajay Chawla. He's a second generation pulmonologist. He is a keen interventional pulmonologist who's working in Saroj Super Specialty Hospital in Jaipur Golden Hospital. He has interest in various newer technologies which are coming up in interventional pulmonology. He is instrumental in organizing RespirCon India every year along with his mentor, his father. And he is a member of a lot of societies. He's very well traveled all throughout the country. Welcome, Dr. Aditya.
Thank you, sir.
And our final person to introduce is Dr. Ganapriya. He's a consultant interventional pulmonologist from Trivandrum, and her interest in interventional pulmonology is basically into EBUS, cryobiopsies, medical thoracoscopy, and ALD, and she has done fellowship also in this in this field of young field of pulmonology. I welcome Dr. Ganapriya on the panel. And Dr. Nagarjuna has covered almost all aspects of radial EBUS, and in the next half an hour, 45 minutes, I would like to break up his talk into different aspects and discuss with our panel in brief and as well as to the point for the interest of our audience. First of all, we all know that radial EBUS came first and then came linear EBUS, but there is some difference between radial EBUS and linear EBUS, and there is a difference in the target area also. So I would like to take a comment from Dr. Samir that what is radial EBUS and how is it different from linear EBUS?
Right. So, very beautifully described by Dr. Nagarjun about the radial. Simply speaking, the difference between linear and radial will be linear is real time and radial is not real time, as Dr. Nagarjuna very well explained in his talk. Um, in linear EBUS, which is famous as the EBUS and is used more widely than radial EBUS, we are using it for mainly for mediastinal lesions, generally for staging of the mediastinum. It started like a tool for staging of the mediastinum in lung cancer cases, but in India we have lots of other indications diagnosing undiagnosed mediastinal lymphadenopathy. The scope itself is a specific EBUS scope in linear EBUS. As I'm sure many of our students or young pulmos who are listening to this, they must have seen an image of a linear EBUS where there is an ultrasound probe at the end of a normal looking adult bronchoscope. Whereas in radial EBUS, as Dr. Nagarjun explained, we use a routine bronchoscope where we put our radial EBUS probe through it and then proceed with the diagnosis. Linear EBUS scope is literally standing in front of a lymph node or looking at a lesion, and we always try to keep the lesion in the center of a conical inverted cone like image. And in real EBUS, as explained by Dr. Nagarjun, either we try to put a scope through the center of a image, through the center of the lesion, so that there is a concentric image, or if it is eccentric, then we have to plan our strategy accordingly. So basically, it is mediastinum versus peripheral pulmonary nodule. I mean, if you have to really give one answer, linear EBUS is for mediastinal lymph nodes and real EBUS is for peripheral pulmonary nodule biopsies, diagnostic purpose. Both can be used for staging purpose. Apart from taking biopsies from mediastinal lymph nodes, linear EBUS now is used. Of course, there are many papers used for many other things like draining a mediastinal cyst or maybe draining even a pericardial effusion. There are, of course, fancy uses, but it can be used for that purpose. There was an interesting paper that I was reading about using a radial EBUS technique also for doing a RFA, radio frequency ablation of a peripheral nodule. If patient is having only that, like what Dr. Nagarjuna presented, say 1 ppn, which is adenocarcinoma, you can actually in the same sitting finish doing a radio frequency ablation and you have given a therapeutic relief
Dr.
also to
Samir,
the
we are
patient.
going to be coming to all those aspects in subsequently in our talk. So basically, what you're trying to say is that radial EBUS is a standalone probe, while linear EBUS is a full-fledged bronchoscope in itself. And radial EBUS localizes the lesion, while in linear EBUS we can localize as well as see how we are taking the sample to it. So that's the basic difference between the linear EBUS and radial EBUS. But initially, when the radial EBUS came, people were using it to identify the mediastinal lymph nodes also. But now, when the linear EBUS came, that work have been taken over by linear EBUS, and now radial EBUS is primarily for the peripheral lung nodules. So I would like to take a comment from Dr. Vijay. Uh, uh, are there different types of radial probes, and what can be their different roles?
Yeah, Ujjwal bhai, thank you for having me here, and thanks Dr. Amita, Dr. Mehul, and IAB for having me here. So, first of all, let me appreciate Nagarjuna for his brilliant presentation. It was such a lucid talk. Really, I enjoyed listening to Nagarjuna. Thank you, Arjun. And coming to the question of what are the various types of radial EBUS, as you were discussing before, so to begin with, radial EBUS probe was the one which was invented first, a dedicated probe which we need to introduce through the scope to assess either peripheral lesions or to the airways. So these radial probes are called as peripheral radial EBUS probe, and then other one is central probe. The central probe, I am using radial EBUS close to 1 decade. So I have never got a chance to use central probe. I have never seen it physically as well. So this was obsolete. There is no, with the invention of linear EBUS, it is no longer required to assess the airway and beyond airway through a central probe, which consists of at the tip there is a balloon. Generally, they used to, as per the literature, filled with water, not saline. So once they filled with water, it enhances it gives the image of the airway and beyond airway, whether the lymph nodes are there or not. So that's what. And coming to peripheral thing which Dr. Nagarjuna has spoke very clearly in his talk, and this is what we are using now. And among this thing, if we want to classify, the different types are from the different companies only. Otherwise, one is from Philips, other from Fusey. So that's from my end, Dr. Ulswell.
So what you're trying to say, Vijay, is that there are two kinds of radial levers, and there are differences in the sheath. One sheet, it comes with a sheet which has a balloon in front in it, so that that balloon is inflated and then used to identify the structures around the airway. We have been using it initially. We have used in certain cases. We have the opportunity to use both a kind of probes. The other probe is a sheet which is blunt, through the sheet through which the probe will come out into the airway. So these are two different types of sheets and the probes which are available. We still use at times the sheet with a balloon to, especially when we are asked by our gastroenterologist to tell us whether there is some kind of involvement of the airway also along with CA esophagus. So there we are utilizing it to see the structures around the wall. So it can be used, but yes, with the advent of linear EBUS, that role has gone down, and now we are practically using the probe which comes out from the sheath. So coming out now, moving ahead from the various types of radial levers to how we do the procedures. So first of all, we need to understand what are the indications. So Dr. Aditya Chawla, can you tell us what are the indications for radial levers and how would you select these patients who are fit enough to go through the procedure?
So, as very well illustrated in Dr. Nagarjun's talk, indications are basically the peripheral pulmonary nodules. Those nodules can be anything leading from cancer to tuberculosis, sarcoidosis, any nodule it can be presented as that. And those nodules should be less than 3 centimeters, then only you are going to use radial EBUS, otherwise you can use a normal bronchoscopic biopsy. Now, basically, the patient selection criteria is those patients who are having on a CT, they're having the peripheral nodules less than 3 centimeter, but around 2 centimeters so that you can access them from the airways. Air bronchus sign is present in the CT, and you can basically lead to the nodule and take the biopsy successfully. Then the patient's consent should be there. The patient should understand the whole process properly. Patient shouldn't have any bleeding disorders. Patient should the checklist of the bronchoscopy should be always followed, and we can go further with the radial EBUS biopsy.
So Dr. Chawla, what you're trying to tell us is that indication is basically any peripheral lesion which is not visible through the bronchoscopes, any lesion which is not present in the lung periphery, which is not visible to us and is of interest. Nowadays, a lot of people are also using radial levers to take a transbronchial biopsies in cases of ILDs also, AS also. That there also it is new. So any peripheral lesion, we are trying to identify the best area to take a biopsy or a sample, and in which the radial EVS is going to help us. The other thing is the other thing that you're talking patient selection is very important because the patient whom we are trying to do this, first of all, should understand the limitations of the any investigation. So that is also important. He should be understanding that. Then the patient selection is important because he should not be having other comorbidities which can make it difficult to manage the patient while doing a procedure. So that's very good. So now every procedure has some contraindications. We can't do it in everybody. So I would like to invite now Dr. Ganapriya in this conversation. So are there any contraindications for these procedures, and what are basically the limitations of radial levers? Will you say that no, radial this patient or this procedure is not for this patient?
Thank you, sir. Thank you for having me here. The absolute contraindication will be like for any biopsy that we do, coagulative disorders will be a contraindication. And patient in exacerbation, an asthma, COPD exacerbation, a refractory hypoxemia, or life-threatening arrhythmias, or a recent MI, those are cases where we will not be taking up. And limitation, like sir said, one thing is it is not real time. Like you are localizing the image and you're taking out the probe and then you're doing the biopsy. And another thing, even though fluoro adds, the conventional fluoro helps, but for smaller lesions and for ground glass nodules and all, it becomes difficult to localize in the fluoro as well. And second thing would be pleural based lesions, where again, you will go for a CT guided biopsy and not a radial biopsy, radial probe biopsy. And one more thing would be in case of eccentric lesions where you need the additional cryo as well and not just the uh, radial probe and forceps biopsy. The additional cryo biopsy would also be required. And in a setting like India, where the chances of infective lesions are pretty high, like tuberculous lesions and all that, the cryo samples will not be good enough for a culture. So that could be another limitation or drawback to it.
So basically, the contraindications are same as bronchoscopy. So whatever is the contraindication for bronchoscopy is also a contraindication for radial EBUS. There are no special contraindications, except for the fact that since we are taking biopsies and we are taking for a peripheral biopsy which are not being visualized, so there could be a slightly increased risk of pneumothorax or bleeding. So that we have to take care of when we are trying to do the procedure. Very good. So now we move ahead and we'll like to again bring in Dr. Nagarjun into the conversation. Dr. Nagarjun, since before we go into decide which patient requires what procedure, so do you have any cutoff that which patient goes for radial EBUS guided procedure biopsy, or which patient is fit enough to go under trans thoracic imaging guided biopsy? So who are the patients fit for which kind of a procedure?
So I think this is a very, very important thing, and it is always asked. I think happy that you have brought up this point, sir. What I would say is that both technologies are actually complementary, and you have to choose. There are no one answer which can tell this is the procedure for him. But in general, what we follow, the closer the lesion is to the pleura, hmm, the more likely we will do CT-guided biopsy. So if it is touching the pleura, then obviously the yield of CT-guided biopsy would be better than radial EBUS. The closer the more farther away from the pleura the nodule is, higher is the chance that radial EBUS will get it. That is the first thing we use. Second is very important is whether you are having a CT bronchus sign or not. Whenever we have a nodule, we always on the CT we hunt for the CT bronchus sign, because if we have a CT bronchus sign, then our yield of radial EBUS is going to be 80%, and then we would be more inclined to choose a procedure which has a lesser complication rate. That is second. Then two more things which have to be pictured in are the finances. So in India, obviously CT-guided biopsy is cheaper than radial EBUS biopsy. Rather than telling I won't do anything, if you cannot afford a radial EBUS biopsy, do a CT-guided biopsy and get him a diagnosis. Fourth is the ability of a person to undergo some sort of sedation. So radial EBUS would entail some amount of sedation. If a person is so sick that you can't give sedation or bronchoscopy, then obviously you do a CT-guided biopsy. I think this is some of the points, but then every case we would discuss with the patient. There'll be some cases where both are feasible, CT-guided and radial EBUS. Then we will discuss with the patient. See, this is what it is. You have two options. This is the risk benefit, and then we will discuss, and then we will come to a conclusion as to what is the best modality.
Exactly what you said. The only one more I would like to add is that there are certain areas which are not very easily, though it's looking a peripheral lesion, but not very easy to access through the CT scan, like scapula, where the scapula is, and the lesions which are closer to the uh, 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 the vertebra. So there are certain areas where you would like to avoid because they are more vascular areas, which will have more complications. So right. So both the choices are there, and we have to choose them wisely. Now, before starting any procedure, we need to do certain tests to understand the requirements and make sure that we are not being little too careless in doing the procedure. So I'd like to invite again Dr. Sami to comment on this. What are the investigations to be done before we start doing this procedure?
Right, sir. So for this procedure, this being essentially a bronchoscopy, whatever investigations we do for a routine bronchoscopy, so we need a CBC to look at the platelets, a PT-INR, because we'll be taking a biopsy, of course, and Triple H and ECG is mandatory where I work. I mean, in my setup, in my institute, the anesthetists have made a protocol that we need a Triple H and ECG also before going ahead. Case specific, suppose it's a heavy smoker, a COPD, we would like to also do a 2D echo and see how is the ejection fraction. And since my institute also does a lot of liver and kidney transplant, of course, the PT-INR is essential, but checking creatinine is also essential, because even if PT-INR is okay and creatinine is high, these patients still tend to bleed a lot. So one has to be ready with then such kind of accessories to manage the bleeding if at all.
Right. And of course, before doing the procedure, we have properly understood the CT scan of the patient also.
Yeah, that goes without
Right.
saying.
So that goes. So an important point that you highlighted is knowing about the creatinine levels also. So any patient having creatinine more than 1.5 has a higher risk of bleeding. So that is also to be understood. Right. This procedure requires little more time than a normal bronchoscopy. So therefore, there is increased requirement of some kind of anesthesia for these patients to calm them down and to make our job little easier. So, Dr. Vijay, what is your consideration with the type of anesthesia that you will be using in this procedure, and whether you will be using some kind of a airway conduit also or not?
So, Dr. Ujwal, I will add one more point to what Dr. Arjun was mentioning. If the lesion is close to aorta, the descending thoracic aorta, something, and probably where even CT guided biopsy may take, will be risky to do it, then probably I would love to do it bronchoscopically. Even if there is no straight bronchus sign, we can use cryoprobe and then probably gain access the sample. And then coming to anesthesia considerations and type of conduits. So as you clearly mentioned, this requires a patient who needs to cooperate at least for if everything is fine. I mean, if there's a straight bronchus sign is there, and the lesion is perfectly 3 centimeters or more than 3 centimeters, that's a, I think, what do you call, dream come true case. Such a kind of case, I would love to do it under a deep sedation. But with the advent of this iGel supraglottic devices, so it is making our life very, very easy to put them under total intravenous anesthesia and do the procedures so that it becomes less cumbersome to us and then less risky to the patient. And then while we take the biopsy, if the patient is, we invariably most of the times we use some form of fluoroscopy or augmented fluoroscopy kind of thing, for which if patient doesn't move, that gives the stability. And in terms of conduit, so if I am going to use cryoprobe, probably I would use rigid bronchoscopy as well instead of supraglottic device like iGel. Over to you.
Yes, you're absolutely right. Since the procedure is longer, these patients tend to cough a little more. And since the radial EBUS is all about anesthetics into deeper sedation or with IGL, right? So, as has been highlighted very importantly in the presentation as well as by the panelists, that knowing the CT scan is very, very important. So, Dr. Aditya, how important is to go through the CT scan properly, and what are the signs which are to be seen to make us believe that we will have a higher possibility of hitting the target as well as getting a positive sample?
So, sir, properly reviewing the CT is very critical when you are doing an EBUS procedure, radial EBUS procedure. The CT gives you the complete information about the lesion. So, first of all, we begin with identifying the lesion, the size, the shape, the location, whether it is accessible to us or not. Then it gives us the assessment of the airway anatomy, whether there is any structure which is going to get damaged during your procedure. Then it helps in planning your approach. It basically tells you that you want to go for a CT guide biopsy, you want to go for a radial biopsy. Then at the end, when we have put them all together, it gives out the yield, that how much the diagnostic yield is going to be in this kind of a procedure, whether we are going to fail or we are going to come out successful in giving the diagnosis to the patient. And also, it also gives us the ways that we are going to avoid the complication, whether it occurs, because if it is much more nearer to the pleura, we may encounter a pneumothorax. So correlation of all the clinical findings is going to lead us to the diagnostic yield of the lesion. And the basically the diagnostic yield depends upon the 2 to 3 signs like air bronchus signs. If it is present, that means we are going to hit the target in the through the airway. And the exact segment we get to know the by location of the lesion, size of the lesion. If it is less than 2 centimeter as pointed by you, we may miss out if the patient does a slight movement also. And if it is less than 2 centimeter, we may turn out to be unsuccessful. And any proximity of the vessels or the pleura or the fissure is there or not. So these are basically the different factors which are going to affect the diagnostic yield of the lesion. And reviewing the CT is very critical.
Right. So most important thing that you have highlighted is the presence of CT bronchus sign. So CT bronchus sign is a bronchus leading into the lesion. So if you have a clear bronchus sign close to the lesion, then you are absolutely relatively sure that you'll be able to hit the target. So that's the most important thing. Location, the size, and the distance from the hilum. These are all relative, but not something which is very
Correct.
found to be very important, making a difference in the yield. So a
Then
difference in the yield is
one thing I forgot. Dr. Nagarjun had showed the slide of the tubercular patient and the malignant patient. So the density of the lesion also is a very good sign to predict that it is going to be malignant or tubercular or something as an infective process.
right. So now we'll move ahead, and now we know that we're just about to start doing the procedure. There is one more very important thing highlighted by Dr. Nagarjun, is that we need to align all our instruments along with each other before starting the procedure. So Dr. Ganupriya, can you just tell us in brief that how important it is and why it is so important to align all the instruments with each other before we start the procedure?
Thank you, sir. So, arranging the instruments prior to the procedure is very mandatory because it avoids the last minute panic and the stress and the last minute run to manage the complications. So, in our setup we do arrange both the adult and pediatric broncho, the thin scope, both are arranged, and we use less of guide sheath, but when it is being used, we make sure that the guide sheath and the probe and the forceps with the stoppers are in place, and the adequate measurements are done. And one thing to anticipate while doing radial EBUS would be, or radial EBUS biopsy would be, one thing would be pneumothorax, and second would be bleeding. So keeping an ICD set or an ICD tray ready in your bronchoscopy suite is a good practice. And another would be to manage the bleed. We do keep our Fogarty unblockers and all standby, along with rigid scopes also as standby in case we need to manage any bleed that happens. And like already told prior by Nagarjuna sir as well, if your suspicion of malignancy is high, it's good to have your linear scope also with you, because that like you can arrange for an imprint cytology or ROSE, and if your malignancy is confirmed, then staging can be done in the same sitting. So complete planning would be essential to do a complete procedure, actually, from diagnosis to staging, especially in case of malignancy. And like Sir said, for eccentric lesions, we do need cryoprobes. So both the 1.1 and 1.7 are arranged, and the freezing time and the working of the probes have to be checked prior to the procedure as well. So these are the usual things that we do prior to before starting the procedure. Yes, over to you, sir.
Right. So there are two aspects which you have talked about. One is how you prepare your instrument for doing the radial EBUS procedure. The other thing is how do you prepare yourself to manage any kind of a complication that can happen during the procedure. So as Dr. Nagarjun in an animation has shown that it is very important to align all the instrument to each other and to know how much the instrument is coming out of that guide sheet, because that is the your actual management measurement that is important. You don't want to undershoot or overshoot the lesion, so you'll miss that. So that is very important. Every instrument needs to be aligned how much it is coming out of the instrument, so that where your ultrasound probe is the actual point where your biopsy forceps is opening up. So that is important, because it's all about measurement. Dr. Nagarjun has totally and multiple times explained that it's a blind procedure. You are identifying the lesion, but your procedure of taking sample is actually blind. So it's all depends on the measurement. So all these measurements and proper alignment of guide sheet kit is important before you start doing the procedure, right? I'll bring again Dr. Nagarjun into the conversation and just want to know, for the sake of the audience, just to explain us briefly that how the procedure is being done once we have set up everything.
Yes, I think for those who joined a bit late, as Dr. Gana has said, once you set up everything, the first step is to reach the nodule. So I think that is where I would say that a thin scope scores much better over a conventional lateral bronchoscope. In fact, the recommendation now is general use a thin scope, or even ultra thin is even better. The more closer you go to the nodule, the more stable your whole setup will be, and the more accurate you'll be able to get. That is the first concept. So you try to go as close to the nodule with the bronchoscope as possible, and that is possible only with a thin or an ultra thin scope. Okay. So once you go close to the nodule with the scope, then what you do through the working channel, you would pass, the conventional way is to pass a guide sheet. That was the original teaching. So I will first talk about the guide sheet. So the radial EBUS is already within the guide sheet, and the guide sheet is passed through the working channel, and then you would search for the nodule. So there might be 2 or 3 subsegments. You will do your pass your radial EBUS probe. The radial EBUS probe will come out of the guide sheet. Guide sheet will come out of the working channel. That is how it is. And then once you identify the image, you're comfortable, you choose 2 to 3 segments. The segment where you get the concentric image is the one where you would sample. Okay. So once you identify the image, you fix everything. Your guide sheath would be fixed with a stopper. Your bronchoscope position would be fixed by you, and then you remove the probe. Then the whole assembly would be fixed. There's no more movement which would happen. So everything is frozen. And then through the guide sheath, the second operator. Now your job is to only be stable. The one who is doing radial EBUS, his only job is to hold the scope and not move. Okay. The operator, second operator will do everything. Through the guide sheath, he will pass the brush. Again, the brush has a stopper, which is prefixed to a length exactly where the red libus probe would have been. And then you jab, take it out. Second jab, take it out. Then put a forceps, do a biopsy. So what is the operator doing? The first operator, nothing. He just has to hold still. This is very important. Okay. So this is how the radial EBUS with guide sheath is done. Okay. The exciting thing is only till you reach there. After that, you might have a frozen shoulder at the ending. That's a different story. Now, if you don't want to use a guide sheet, then the operator will have some more task. So if you don't have a guide sheet, then you have to know where you have to direct your accessories. So if you don't use a guide sheet, you put a radial EBUS probe accurately to which subsegment you are going, how deep you are going, what depth you got the image, you memorize. Then you always want to use a additional fluoro if you're not using a guide sheet. So on the fluoro, where you got the image, where your probe was, you mark. If you're not seeing the nodule on the fluoro, if you're seeing it on the fluoro, it's okay. So you always use a single dimension or a multi-dimensional fluoro. Once you are sure that you are there, then you remove the radial EBUS probe. Now the operator has to again send your forceps to exactly same depth, same subsegment, reconfirm on the fluoro you are in the same position as where your radial EBUS was, and then take a biopsy. So that is about if you don't want to use a guide sheet. So this is in brief about how radial EBUS is done.
Excellent, excellent. This is all experience. So first, very important thing you have said is your bronchoscope has to anchor inside the airway. It has to anchor inside the airway so that your scope cannot move further inside. So that's the right place for the bronchoscope to be, and then your sheet will come out, the radial probe will come out, and there you have to stabilize yourself. So that's very important. The other important thing you have highlighted is to rightly identify which is the right target to be sampled. So there you might see a lesion in one segment, but that may be eccentric. So it's always wise to come little out and go to the other segment and see whether your probe actually reaches the center or not. So that would be a better place to take the samples. Right, exactly. Very good. And now I'll bring Dr. Sameer into the talk. So we have now identified the lesion. So what are the various kind of ultrasound images which are important to be understood, and which is the right image to be looked for, and what is the difference between the yield if we have different kind of images?
Right. So, as discussed by Dr. Nagarjun in his presentation, the blizzard sign and the other signs that he showed, they are, of course, they are available on the study material on internet. The most important aspect I felt and I feel while doing Radial EBUS is, you also just now mentioned in your last remarks that you have to be in the center of that lesion. If you are able to have that concentric kind of a what do you say, design around you, then you are very safe and you will get good yield above 80 to 84%. If it is eccentric and you do not have a cryoprobe, that's a very good point taken from Dr. Nagarjun's talk today, that we do struggle with routine forceps and brush biopsies when it's a eccentric this thing. So make maximum attempt to manipulate your scope and your radial EBUS probe in such a way that you are trying to stay in the center by changing, coming out, and again going to the certain segment. If unfortunately you are not able to still do that and it's an eccentric image, then using a cryoprobe is probably a very good alternative to get a good biopsy, but keep the bleeding and pneumothorax part in the mind, although it is just 1 to 2%. So I think getting into that concentric image is the key to success of getting good yield, is what I feel after practicing it for a while.
Right. So basically, there are two kinds of lesions we are targeting: a solid lesion and a GGO. There are different kind of images which will come up. Solid lesion will have a solid image, whether it is a concentric or eccentric image, that's other aspect to be seen. And those GGOs may have a blizzard sign, which Dr. Nagarjun has talked. And in case we have got a mixed kind of a opacity with some solid component, it's going to be a mixed blizzard sign. And typically mixed blizzard sign, as he has shown in one case also, would come in our setting, would come in tuberculosis. So that's an important thing to understand. So all these signs are very important, and it's important to know what is the difference between the snowstorm appearance of a normal lung and a blizzard sign. So as soon as you are seeing a blizzard sign, you are a little confident that you read that area. So that's important. The other important aspect that he has highlighted in his talk is where to position your sheet. You should position your sheet just when the image is coming up, so that you have the full access of the nodule. So you have left your sheet over here, you have the nodule over here, so you have full access with your instrument inside. So that's very important. So right. So now, Dr. Vijay, so what all procedures can we do through radial EBUS, and what all samples we can collect and send them for the investigations?
Right. And whenever we are using radial EBUS, it is very important to know the first shot itself. Whenever we are taking a biopsy, you should take it from the maximum point of interest, because once the biopsy is taken, the bleeding chances will be there, and once bleeding occurs, then everything will be, the image quality will be spoiled, and then you will be failed to again, if you want to check by placing a radial probe, you will have spillover of the blood into the other segments, and you may get chance of different kinds of artifacts, and then false images are likely. That's why please remember, okay, when you are attempting biopsy, get the maximum point of interest into the vision, use the fluoro or augmented fluoro, and then get the biopsy. And then apart from that, So as one of my, Dr. Aditya was mentioning very clearly, and radial EBUS can also be used in identifying the maximum site of interest in DPLDs as well. And coming to the other important thing, various kinds of samples, but what we do can collect is one is imprint cytology, brushing, okay, and then get the cytology, get a good quality of ball after identifying the lesion into the particular segment or subsegment, and then initially, just to recollect our beginning days, Dr. Uzwal, okay, it was very, very difficult with the biopsy forceps that Olympus people have provided to us. The samples were in millimeter. So then what we have done is, in those days, we have replaced and took out the guide sheet under the fluoro guidance. We used to use the conventional biopsy forceps to get the good chunk of biopsies. So that can be done. And then in those days, the guide sheet flush was very, very helpful. And then we used to send for cytology as well after flushing the guide sheet. And with the advent of the cryo probe, particularly 1.1 and 1.7, life has become very, very easy, and using radial EBUS and then biopsy of the SPNs particularly. So, and I haven't had any experience regarding the peripheral TBNA, but Arjun was mentioning his talk. In his talk, I have read only. I haven't used any peripheral TBNA. So essentially, cytology, ball, guide sheet flush can be used. Forceps biopsy, if not with the small tiny forceps, we can use conventional forceps once we know that lesion is reached, and then cryobiopsy. Cryobiopsy with particularly 1.1 and 1.7 has made our job very, very easy.
Correct. So basically, three types of samples we are trying to collect. One is basically biopsy, the other one is cytology, and then a liquid biopsy or a BAL. See, these are the three major samples that we are trying to collect, and this should cover up for malignant lesions, and this should cover up for the microbiology or bacteriological lesions also. So these are the three things to be looked for. Biopsy, as you rightly said, can be taken with a forceps or with a cryo probe. So that is something which can be done. So important. One more thing which is very important to understand is that whenever we are taking the samples, what should be the correct order of it? As rightly mentioned in the talk, if you're trying to take the brush cytology and the biopsy also, brush cytology also always should be done first. And then we should be doing biopsies. And after that, we should be taking lavage. So that's in order that we usually follow. Right. So no procedure in IEP is without possibilities of complications. So there can be some complications. Dr. Aditya, what are the common complications we need to look for, watch for, and how do we manage them?
So the common complications are same as in a transbronchial lung biopsy. We are doing a bronchoscopy and doing a biopsy. So we can encounter pneumothorax, we can encounter bleeding. So these are the two main complications which may occur during a radial probe EBUS. Other than that, hypoxia, any bronchospasm, cardiovascular event, and we need to be prepared for each one of them all the time. We need to have all the uh, instruments in armamentarium in your bronchoscopy suites, whether you encounter anything, and at that time you need to act fast.
So right. You rightly said that there are two major things to be looked for. One is bleeding, the other one is a pneumothorax. So these two things are to be looked for. And if we are not too periphery into the airway, pneumothorax chances are much less.
Much
Bleeding
less.
becomes little more important. And if the lesion is too periphery, then chances of pneumothorax is higher. Lesion is too proximal to us, the chances of bleeding are more.
Bleeding are more.
So any lesion in between these two lesions is relatively a safe lesion, right? So we need to be prepared to handle all these if you know this. After doing a procedure, there's always important and certain things to be watched for in a patient in a post-operative period. So Dr. Ganupriya, can you just tell us how do we observe these patients? What are the things to be seen in a post-op period?
So in the post-operative period, we normally observe the patient for about 2 hours in the post-op EBUS plus in the post-op period, provided there are no intra-op complications. And in a patient that has not had any intra-op complications, then in post-op period, we advise for an X-ray as well after 2 hours. We do a fluoro shoot in the OT itself, but then many a times the pneumo develops 1 to 2 hours later. So even though the fluoro shows lung movements, diaphragm movements are good, we still do an X-ray 2 hours later to confirm that there is no pneumo. And the regular vitals monitoring and all is done with ECG and oxygenation and BP monitoring. But for those patients who have had any event, we do admit them. And in case of a severe spasm or an exacerbation, when you do ILD procedures and all patients in ILD, they do go in for exacerbations as well. So in those cases also, we might have to keep them for a day. And those with severe spasms, yes, we do advise nebulizations also.
Right. So majority of the things that we have to watch after the radial EBUS is same as any other bronchoscopy procedure. So there's no change as such, no extra thing that we need to do. We need to follow the same protocol that we are following whenever we are doing a bronchoscopy. The only small thing is that since we are taking blind biopsies and whenever we are suspecting a pneumothorax, we may do a CT scan. Doing CT scan may not be absolutely necessary in every case of a radial EBUS biopsy. If we are taking biopsy from relatively bigger nodules, and we do not need to do the pneumothorax checks with the help of, say, X-ray chest. Otherwise, this is all routine observations. Now, Dr. Nagarjun, the rose is coming up. The importance of rose is there in a linear EBUS. Is it important to have rose with radial EBUS also? You have talked something about this in your talk, but how important it is, and are you doing it?
Sir, I feel if you have access to a pathologist who can come and help you, it is always beneficial. So there are in fact a lot of studies, and recently there is a meta-analysis also, I didn't show it, which has shown that ROSE can increase the diagnostic yield. So how will it increase the diagnostic yield? Basically, the operator will take more samples till the time the pathologist gives the diagnosis. So that is the basic concept, one. So there is some evidence to say that ROSE can increase diagnostic yield. Two, what we personally feel is that ROSE helps in triaging our sample. Suppose you find atypical cells, then you would want to take a little more larger tissue for whatever molecular studies. If you find inflammation, you would want to take a good bulk. So it will help in triaging and deciding whether you want to do simultaneous staging EBUS. One of the advantages of radial EBUS bronchoscopic sampling over CT GAT is the fact that you can do simultaneous staging EBUS. That is where ROSE actually helps us. In a peripheral nodule, if you find atypical cells, you do simultaneous staging EBUS and come out. That is how it helps us. But two catch points. One is that the pathologist also has to be competent, which is very, very important because not in all centers you have pathologists who can tell on a rose station. So see, interpreting on a rose is little supposed to be little more challenging than interpreting the biopsy or this thing in your pathology office. So you need to have a pathologist who is competent in interpreting on the station. Second, also is there are a lot of people who have sort of adapted and modifications of pathologist rows, which I had said are the pulmonologist rows. I'm aware that in India, some centers are actually following a pulmonologist rows, which means the pulmonologist is trained in basics of at least identifying atypical cells and inflammatory cells. There is also a concept called as telerose. If you have a microscope which can be connected to your pathology, the pathologist can see. And PGI has also now published a paper called as WhatsApp Rose, where the bronchoscopy technician will take an image of the camera on the phone and send it on a WhatsApp to the pathologist, and that also has been published and shown to be better than without rose. So a lot of things are happening.
That is robotic pathology. Uh,
Yes.
rightly said. See, the dose has decreased, is set to decrease the amount of time that you do a linear reverse procedure. It hasn't shown to increase the yield, but it has shown to decrease the time spent doing the procedure. When you're doing radial levers, it is a blind procedure. when you're taking biopsies. So whether you have hit the right area or not is very important. The other thing is that whenever we are doing biopsies or taking samples from the lower lobe or dependent part of the airway, lung, that lung tends to collapse and tends to look like a lesion. So there, if you're taking a sample and that sample, you may think that you have hit a lesion, you may think that you have taken a correct sample, but that may come out to be a normal lung. So it's important, becomes important if somebody is there to guide you. Rightly said that. So now we have taken the sample with the so cryo is a new forceps, which is a versatile forceps in doing everything. So, Dr. Sameer, some people are using cryo probe guided cryo biopsies with the radial EBUS also. Is there any advantage of doing a cryo biopsy with radial EBUS?
So, as rightly said in his talk by Dr. Nagarjun, that if the lesion is eccentric type, despite of your best efforts to make it a concentric one by maneuvering your radial EBUS probe, if you're getting an eccentric kind of a lesion, I think I have personally not used, but in such a scenario, but I'm sure that is definitely going to give us a better yield. However, there are other papers which have said that if you are having a concentric lesion, the yield by a typical biopsy forceps and a cryobiopsy forceps is not more than 2 or 4% here and there. Uh, although I have not personally used, I have liked the concept of using it in that particular scenario. I think we'll remember that, Dr. Nagarjun. Thank you for that learning tip.
Well, we have been using cryoprobe. See, the advantage of using cryoprobe is one, that you are sure that your probe is going to come back with the biopsy. At times, the forceps doesn't open. You're struggling the forceps to open up, and when it is opening out, it may open up in a different area where the lesion is from the lesion is. So it's where that decreases our yield. So with cryoprobe, we are sure that we are hitting the target area. So that's very, very important. The other thing is, as rightly pointed out by Dr. Nagarjun and you also, that in case there is the eccentric lesion, by the virtue of the kind of biopsy that cryoprobe takes, it takes all the surrounding area along with this. So your chances of missing the lesion are much less with cryobiopsy. And with the availability of 1.1 probe and a sheet which comes along with this, you can even use that sheet to take a biopsy. Though the biopsy size is going to be a little lesser, smaller, but that biopsy is relatively safe to be taken. So that's cryo is actually a next level of biopsy when we take out. So this is all about taking biopsies. But there must be some tips that we would like to give to the audience how to improve the yield. Dr. Vijay, so do you have something more to tell us? How do we increase our yield with radial EBUS?
So basically, by this time, we understand very clearly careful identification of the patient, not to promise, okay, over promise and under deliver. That is not correct. Okay, you can better, under promise and then, over deliver. That's what practically I feel, okay, it's going to enhance the yield. And then probably, even if we under promise, the confidence levels with which we do the procedure is also high. And we also know that having a CT bronchus sign and then lesion size is good enough, like 3 centimeters or more than 2 centimeters, and usage of ultra thin scopes are not really happening in the in at least our country. So I suggest to use usage of ultra thin scopes for biopsying or using radial EBUS. Cryoprobe we discussed enough, and Arjun was clearly mentioning usage of ROSE in radial EBUS. We haven't started for radial EBUS, and with this webinar I will insist my pathologist to help us in starting radial EBUS lesions as well to do the ROSE. And definitely the presence of navigation system, I think is going to enhance. We don't have it, but Arjun should add, because he has a good amount of practical experience, and I'm sure you also have the very good practical experience. Usage of navigational bronchoscope is one thing, which is going to probably enhance the yield. Over to Uzwal.
Sir, I have a
Right, right.
query. Sir, I have a
Yeah,
query.
Yeah.
yes,
Even I have
Aditya.
a query, and maybe the audience also has people in the audience may also having this query. I don't have the luxury of doing 1.1 cryo probe I'm using, so we are using 1.7 without the sheath. But what is your experience? You, after putting the sheath, when you're doing the cryo biopsy, you remove the cryo probe in toto as we do in a cryo biopsy, or you leave the sheath inside and you go through the cryo biopsy, and if the piece falls down, what is the solution in that?
Vijay, you want to answer this?
First of all, there is no point that piece will fall down. Okay, the biopsy sample will come intact. So, and I don't think such a kind of scenario I have encountered so far, that missing the sample.
So you leave the sheath inside and you remove the cryoprobe through the sheath.
To be honest, I haven't used the sheath so far. Okay,
True.
there is no need.
That's what I
Aditya,
was trying to ask.
Aditya,
Sir.
with 1.1 Pro, the company provides a sheet,
Okay.
right? So that sheet has quite a good lumen size. So if you take a biopsy through that sheet, you can remove your cryoprobe, leaving behind the sheet,
Okay.
and come out with a biopsy for it. You
Okay.
are absolutely right that if you're using from the same small guide sheet which is provided in that kit, you might the piece may not be able to come into the into the sheet and through out
Lumen.
into the
Right.
so you may have to bring out the whole assembly out. So, but with the use of that sheet, you can still do that. But the important problem with that is that in that situation you have to make other kinds of measurements to be able to do that. So most of the time when people are doing the cryobiopsies with thin or ultra thin bronchoscopes, they're actually coming out with the biopsies with the probe. So that is the normal teaching that people are doing when you're using without a guide sheet. Right, right, right. So this brings us to the next point, that it's very, very important to reach as close to the airway as possible. So how does ultra thin or a thin bronchoscope makes a difference in the outcome of radial EVA, Dr. Aditya?
So, sir, basically, thin and ultra thin scopes, as Dr. Nagarjun has shown and illustrated in the slide, both have the measurements and the advantages and disadvantages. So it all depends on the location of the lesion. If it is mid bronchi, mid airways, the thin scope will score better than the ultra thin. If it is more towards the periphery, we can use the ultra thin scope. So the ultra thin scope has better maneuverability. It can go further in the generations of the bronchi, and the thin scope, it has a little limitation that it will stop in the mid airways, and but the when you are having the lesion in the mid airways, thin scope always scores better because you have a better vision, better lumen size, better workable channel, and we can get big biopsies. When you're using an ultra thin scope, you have small biopsies, vision is a little less, and it is a little difficult to maneuver the thin scope in the periphery. So it basically complements the location of the lesion, the comfortability of the operator and the patient which we are operating on.
Right. So depending on what you see on a CT scan, you would decide whether you would use a thinner scope is enough, or you need to use an ultra thin. But I think if you're using ultra thin, that the Dr. Nagarjun has rightly highlighted, you cannot use the sheath. So in that case, you'll have to do radial EBUS without sheath. So that's an important point to remember. The other thing which my panel would always would agree is, at times this has happened with me. I thought of doing a radial reverse in a patient, but when I use the ultra thin bronchoscope, I actually could reach up to the lesion and take up a biopsy instead of using a radial. So that can happen. So that's the reach of ultra thin bronchoscope. It can take you to eighth or ninth generation subdivision. So that's the advantage of things. So ultra thin, if you have with you, is always a benefit that you have. So now we are coming to the end of our discussions, but it will not be over without using the newer technologies along with Radial EBUS. There are lots of navigational technologies which have come up, and they are complementing our Radial EBUS procedure. So, Dr. Ganupriya, can you just highlight on those navigational procedures and how they're helping in improving the yield of Radial EBUS?
I think navigation bronchoscopy mainly the factor here is time and how brain tracking manual mapping can be. So basically, with navigation bronchoscopy, the software is guiding you. It is real time. It gives you multiple paths to lead to the lesion with your a lesion with a bronchus sign. So you are able to identify the path or choose the path which is feasible to for a good biopsy. And also basically it is the time factor, that is it is less time consuming than the manual mapping method, but in a resource poor setting or in a setting where you don't have navigation, I think manual mapping still holds good.
Right. So navigational technologies are newer technologies which are helping us to reach as close to the lesion as possible, which was not possible earlier on. So it is definitely improving our yield, as Dr. Nagarjun has already said. So Dr. Nagarjun, you have been the pioneer of introducing these navigational technologies in India. So you want to add something to it?
So definitely, if you have access to it, I would say that we don't use it in all cases. So we choose it in smaller nodules. In fact, the literature also says that if the nodule is less than 3 centimeters, so 2 or lesser, then addition of a navigation would probably increase the diagnostic yield. But if you have a large lesion, then I don't think that you would benefit by using a navigation. Again, I would say there are two types of navigation technologies. One is the technology which would take you only within the airways. So that is the lung point by bronchus and synapse by Fuji. The next generation navigation systems are those which would also give an extra bronchial path. So they would map the vessels around the airways, and they would also give you a puncture point and take you out of the airway. That is called as extra bronchial tunneling, and that is what we call as Archimedes. So there are two types of navigations: intra-bronchial navigation and the navigation which takes you out of the airway. So, but in a very small subset of them, you would want to puncture and go out. So that is not again a point of discussion today, but that is my take on navigation, that for smaller lesions, it would help. But if you master manual navigation, probably you would be as good as a uh, computer-based navigation.
Right, rightly said. We do not have access to navigational technology. So what we are doing is, in case we are dealing with nodules which are 1 centimeter or less than that, we go to our CT scan center, sit with our radiologist, and in with the different kind of views, he will tell us what is the right pathway of reaching to that area. So that's a thing which we have also highlighted. So if we do not have navigation technology, if we can use this brain power of different people, radiologists and yourself, you can still be doing a good navigational work. Very good. So now important comes is now is there a simulator which can help us in learning this procedure, Dr. Nagarjuna, better? Do you think there are simulators available, or this has to be learned through the experts only?
So when we were learning, it was all on the patient, never learned on a simulator. But now I think simulators are available for learning, and always simulator-based learning before on the patient learning is said to be the correct way forward. But not many centers have access to simulators. Again, as we have said, so we should actually probably go for conferences where simulator-based training is there, or choose centers which have simulators. There are certain centers in our country where you have simulators. Nothing wrong in doing simulators, but I think the vast majority of us would learn on the go as we keep doing on the patients. And after a certain number of procedures, again, there's no fixed number, I would say, maybe 20, 25. I think your skills of the Redilibus would slowly increase. It would take some time. In fact, Redilibus has a more uh, slower learning curve as compared to linear EBUS. I think this has been shown globally that for linear EBUS, you see five, you do five, you this thing, and then you can do. But Edelibus, I think it takes time. So it over the years, your skill would improve. In the initial years, maybe your yield would not be very great. But then as you keep doing, then your yield would definitely improve.
Right, right. You have rightly pointed out the learning curve of radial EBUS is longer. And initially, when linear EBUS came, why it became very popular? Because learning curve of doing conventional TBNA has become very short. So now conventional learning a proper doing conventional TBNA of real lymph nodes was difficult earlier on, and people would give away doing conventional TBNA all because it was difficult to master the outcome of what the other experts are saying. So this brings us to our end of our panel discussion. Before we take up the questions from the audience, what they have given, anybody else want to give any comment?
No, one important thing I want to highlight here, Dr. Ujjwal, is radial EBUS probe is very, very delicate structure. You have to give a lot of respect, lot of care. So otherwise, probe damage can occur. So they cannot use like our linear EBUS scope, left and right. They cannot use. They have to handle very, very carefully. That's what is one point I want to add to the discussion.
You're absolutely right. We were probably the first people at Gangaram Hospital who started doing radial EBUS. We bought radial EBUS in 2010 along with linear EBUS. And initially, just because it was a very thin one, we were always very skeptical of using it. तो ये टूट ना जाए, that then it will break, then what we will how will we answer our administrators? So we were also not using very often, but since 2012 onwards, 11 12 onwards, we have been little more frequent. And you rightly said it's a baby, and baby needs to be handled very nicely and very properly. So that's very important. But if you're taking all care, doing 150 to 200 procedures per probe is not difficult.
Aram se
It's not
Ajay.
difficult.
True.
It's
True.
not difficult. And some people have been able to do more than this also, but our average is around 200.
Our first probe came for 400 cases.
Yeah, the problem comes when you start using it without guide sheath.
True.
There, the chances of the probe damaging is little higher, because then there is nothing to hold the sheath very nicely. So there is something. But if you are using with sheath, chances of the longevity of the probe becomes more. So now let's go on and take the question answers from the audience. If there are some questions, let me see. Yes, one question is from Dr. Ajay from Pune. He wants to know what are some of the tips to optimize the yield of radial EBUS sampling, and how can we minimize the risk of complications. Vijay, can you answer this?
Yes, we have discussed thoroughly about the tips of optimizing the EBUS sampling. So ensure that, as Arjun was mentioning, try to use whenever the navigations are not available, try to use your brain gray matter and then discuss with the radiologist. It's always, for particularly first few, maybe around 20-30 cases, every case is a new experience, to be honest. But again, for at least for 20-30 cases, sit with your radiologist, if required, 2-3 radiologists, and then discuss with your colleagues what is the map, okay, how you are going to access the nodule. So this clarity, if you plan well in advance, rightly, if I want to mention at least a day in advance, then the things will be much smoother. So this is how you can optimize the EBUS sampling. And whenever you have a chance, try to use navigation and also cryo. So I personally feel, so cryo instead of only in eccentric lesions, it will also be useful in the even if the radial EBUS probe can reach into the center of the lesion as well. Cryo probe usage is going to increase the yield for sure.
Right, right. So important thing to know over here is that, like any other IP procedure, I would like to add this point. This procedure also requires a teamwork. So to improve the yield, the whole team has to put in. They have to understand what the procedure is and to participate in taking the correct sampling and doing the correct procedure. So that's very important. The team needs to know. As Dr. Nagarjuna has said, that the person who's identifying the lesion becomes actually a stationary person, And the people who are taking biopsies are actual heroes in the end who would come and take a biopsy, right, Dr. Nagarajan?
Yes, that is the fact
Hmm.
also. Samir.
So that is a fact. So the person who is doing a procedure, having a bronchoscope in hand, rightly said, would have a frozen fingers and frozen shoulder. So that happens. And if the person slightly moves, the whole team, the result of the whole team goes haywire. So that's the importance of a teamwork. So develop whenever you're doing these IP procedures, these kind of procedures, you should have a good team with you. So that's important. So coming to the next question, and this probably is for Dr. Nagarjun only, by Dr. Sanket from Jaipur. He wants to know how to integrate radial EBUS into clinical practice and what are the key factors to consider when you are deciding whether to use it or not. How to integrate this into the clinical practice.
I think the first thing is we should be open to using it. We should close our minds to the fact that CT guided biopsy is the end of everything. So that is the first thing. Still, many people keep asking, what is the whole, why do you want to do all these things? So there is enough data to say that if you have a radial EBUS, you can get the same diagnostic yield at a lesser rate of complications. I think that is the first thing which you have to understand. But at the same time, what I would say is for any peripheral bronchoscopy, as Dr. Ujjwal sir was telling in the morning, in the beginning also, not necessarily a nodule. Even if you have a segmental consolidation or anything cavity wall, adding a radial EBUS to your bronchoscopy and seeing the target would increase your confidence that you are there and would increase the diagnostic yield. This is something which we have to understand. So radial EBUS is not only for nodule, it can be used for small consolidations, it can be used for cavity walls, it can be used basically for any peripheral bronchoscopy, and that is how you integrate radial EBUS into your clinical practice. So for any peripheral bronchoscopy you are doing, have a ready libus by your side. Try to see the lesion, confirm that you are there, be more confident that you are exactly there, and then do the sampling.
Right. So if we are able, if we want to increase our diagnostic abilities and want to diagnose even those small lesions in the lung, which is becoming important in the era where we are doing a lot of lung cancer screening and all those. If we want to venture into it, it's important to learn radial EBUS because then only we are going to be able to help these people. Now coming to another question, Dr. Samir, this is for you by Dr. Vijay from Delhi. He wants to know how to select the optimal location for radial EBUS sampling.
I think it has been answered adequately in all throughout our discussion, discussing with your radiology colleague and studying the CT scan thoroughly. And while maybe using a thin bronchoscope or ultra thin bronchoscope and a fluoroscope at the same time. In my institute, we also have a luxury of, if required, using a cone beam CT. So even if we are not able to map it on the CT scan films on the radiology console, we still have a luxury of using it. So just knowing the anatomy properly and maybe rehearsing that procedure in your mind, maybe a couple of times, how I'm going to go about it, can help us, reach the target area properly, knowing your bronchial anatomy, knowing your radiology. I think, and using fluoroscopy, if there is no cone beam CT, using fluoroscopy properly can help you reach your target. I think 99.9% of the time.
Right. I think when we are talking about radial EBUS and when we are talking about the use of radial EBUS in masses, then we are probably talking about doing radial EBUS as a standalone procedure without um, 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 any possibility of using other navigational. So in those settings, rightly localizing the lesion is by understanding the ultrasound images. If you understand these ultrasound images properly, you'll be able to identify the lesion. And if you identify these lesions, then if your hand is very stable and your team knows how to participate in the procedure, you'll be able to take the biopsies and they take the samples. So that is the important thing highlighted over here. Now coming to another question, which is actually challenging, and it's a very good question by Dheeraj from Patna. He wants to know what are the some common technical challenges which arise during doing a radial EBUS. So I tell you my question, Nagarjuna. At times the biopsy forceps doesn't open. So how do you open that biopsy forceps?
So, at I think technical challenge, one is that things, the forceps doesn't open more often with the thinner forceps. That time, I think doing multiple things and having an additional fluoro sometimes will help. So actually can see the forceps opening. But as you had rightly said, sometimes it doesn't open. It also depends upon the density of the nodule where you are. If it's a hard nodule, sometimes it may not open. The only way is you have to do multiple biopsies. That is the only thing I would say. That is one challenge. But then I think the most important technical challenge in radiolibus is not identifying the nodule. That is the biggest challenge. And even now it happens. Despite whatever planning you do, whatever navigation you do, what happens is for several reasons. One, there may not be a path. There may be a path, but which is narrow. There may be a path, but which is too angulated that your scope can't go. So for all these reasons, you may not see the nodule. If you don't see the nodule, that is the end of the thing. So you cannot do the procedure with certain exceptions that I would not talk. Okay, that is the most important technical challenge with the radiolibus. Second technical challenge is anticipating a concentric image and ending up with an eccentric image. Many times it happens that you find a nice CT bronchus sign, but when you go inside, you'll be disappointed that you are getting an eccentric image. So in that situation, two things can be done. Switching from a thin to ultra thin. That will help because you would be able to go maybe a little deeper, find a narrower branching, and then get a concentric image. So switching thin to ultra thin has sometimes helped us. Second, which Dr. Ujjwal has already said, if you get an eccentric image, don't lose hope. Search for the adjacent segment, you might get a concentric image. The last thing is, if you get a concentric image, eccentric image, and continue to get eccentric image, then two things can be done. One, either a cryobiopsy or in the future, a peripheral TBNA. The two things which have been shown to increase the yield in an eccentric image is cryobiopsy or a peripheral TBNA. So that is the second challenge, getting a eccentric image. The third technical challenge is losing vision. So after the first biopsy, Vijay has rightly said, in radiolibus, the first biopsy is the best biopsy because you may not get the chance to do another biopsy. So I will always tell them that the first biopsy has to be the most accurate biopsy, and that is what which would help you clinch the thing. So many times it can happen, especially when you're using an ultra thin scope. The vision will be bad after the first biopsy, and then the radiolibus image also. If you do next again, it won't be original radiolibus image because you will have some bleeding which would look like consolidation. A lot of things will happen. So you have to be very sure as to where you have to go because doing a radiolibus after a first few biopsies may not always give the same original image. That is the technical challenge, but there are a lot of technical challenges also. I can keep talking, but I will stop here.
Right. So just add 2 points to this. One thing about localizing the lesion. Somehow we were lucky because we bought radial levers very early in 2010. We have the guiding device. So that guiding device at times helps us. It's like a finger. So you can move your finger and then you can enter. So at times it helps. At times it doesn't help because at times there are divisions, but they're actually not visible. So when the division is not visible, with your white light bronchoscope, you cannot enter that. You can enter only what is visible. So you rightly said that despite the fact that you went into the doing a procedure that it's a very easy one, you may come out empty-handed. So that's one thing. The other thing about taking sample. So you have rightly said that correctly identifying and probably taking a cryobiopsy in those eccentric lesions would help. So that has increased our yield. We have also observed that our yield has increased. Now about forceps. So what we have, what has worked for us is when we do the procedure, the forceps biopsy is coming out empty-handed time and again. What we do is we agitate it. When we open, we agitate it inside the disc. So at times it opens up. So that's something which can help, which can help. Right. So let me move forward, and we have a
One
question from.
experience I want to share. When I was talking to Professor Kurimoto from Japan, okay, he was mentioning as well that his chances of accessing using an ultra thin bronchoscope for a 1 centimeter lesion or less than that is 85%. So here I want to mention expertise. The more number of cases that you start handling, I agree completely with you. And then Professor Kurimoto was also mentioning the same. So the more number of cases that you gain experience, the easier the radial EBUS becomes.
So it's like any other procedure. Your hand movement becomes so that they help you navigate through inside. So that's it. That's very well said. So now coming to another question from Goa, Dr. Gaurav has asked how to optimize the setting of EBUS scope to get the best image quality. Aditya, do you want to answer this?
So, sir, the best quality of the image when you are inserting the radial probe EBUS, you need to position it correctly so that you get a concentric image. And then you can adjust the frequency and the depth according to you, which image you like to have on your screen. Like if we are doing an EBUS, linear EBUS, we are decreasing the depth and the image becomes more clearer. So that the same principle applies to the radial EBUS.
So, yeah, right. So, most important is to anchor your bronchoscope properly inside and then look for the best image
Correct.
with a very stable bronchoscope. And then movement is only of the probe, radial probe. So, that's important. Now, coming to the next question, this is by Mangesh from Mumbai. He wants to know what are the key differences between radial EBUS and linear EBUS. I think we have answer
Discussed.
this, and how to decide which one to use. Well, it's very simple. Linear EBUS is for the lesions around the major airways, and radial EBUS is for the peripheral airways. So this is what we have defined. We have segregated the use of these two things. Coming to the next one, there's a comment by Dr. Vijay. Very much insightful and very well structured presentation. Thank you very much. And this I'm saying from the Nagarjuna side also. Uh, this is from Saket from Hyderabad. How do you manually map the CT scan? Aditya, how do you manually map CT scan?
So manually mapping in the CT scan is again, as Dr. Nagarjuna said, use your cerebral cortex, use the cerebral cortex of the radiologist. And then when you have the CT scan, the image he showed, manually mapping the airways. So all airways are a rule of two. So you manually map the airways, you see on a console how the lesion is reaching, how you are reaching to the lesion through the bronchus, and then you manually map it on the paper, manually map it on the paper, and then you follow the path when you're doing the bronchoscopy. So that is manual mapping. Even literature is available, a paper from China who started doing the manual mapping and the CT mapping, and it is going to help if you read that literature.
Right, right. So if you are doing bronchoscopy very systematically and you're doing that divisions, you know that B1, B2, B3, you're mapping all that. One person, one assistant with you can always keep a record of where you are entering and which branch you are entering. I would say this is more theoretical. Practically, you have to do it, and practically
Correct.
everybody has a different kind of anatomy. So there is another comment by Dr. Ajay. Clear, engaging and informative session. Thank you very much. Excellent delivery, clear visuals, impactful insight. Nice session by Dr. Dheeraj Patna. Thank you to you also. Now, this is from Dr. Gopal from Gujarat. He wants to know why are we so much aligned to the costly EBUS biopsy of the peripheral lesions, while we know that CT guided two cut biopsy is rather better than EBUS biopsy.
So Dr. Nagarjuna has correctly pointed. If the lesion is near the pleura, we go in for CT guided biopsy. We don't use a radial EBUS biopsy. So we should know when to use and when not to use. Always the judicious use of the technology is said and told and taught by the professors, and it has been very correctly illustrated in the whole seminar and his talk that peripheral lesions near the pleura, they are for CT guided biopsy. We go for only those which are peripherally but not to the pleura, and in the mid airways which are not reachable by the normal bronchoscope, we go for the radial probe biopsy.
Perfect.
Right. So basic answer is the clear conscience lies with the physician.
Correct.
He needs to decide properly which is good for the patient. The cost is a secondary thing. First thing is we should be able to give a diagnosis. So that's it. That's very important, right, Dr. Nagaraju?
I think, sir, now it's cost and safety. Now has come the era where if we talk to the patient that you have to choose a procedure with 10 to 15% complications versus 1 to 2% complications, a vast majority of them would choose a procedure with lesser complications. And that is where Radial scores over a CT guided biopsy. I think this is one thing because every time we say cost, 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 yes, cost is a concern for a subset of population, but cost is not a concern for another subset of population where safety is more important prerequisite for them. I think in India we see both groups of people. So I think it is you in conjunction with the patient who would decide what is the correct modality for that particular person. You should have skill set to do both.
Yes. And it is very easy to say that we can do CT guide biopsy. There are very few radiologists who actually would like to take the risk of doing a biopsies. So they would say no. So you need to have a radiologist also who's willing to take a CT guided biopsy or a image guided biopsy. That is important. So not every place would have a luxury of having such a interventional radiologist also with them. So that's also very important. The other important point is cost. I think cost maybe 20 years down the line or 15 years down the line was an issue. But now if I talk about cost, in Delhi NCR, we have got more than 60 more than 30 EBUS, linear EBUS. So where is the issue of cost?
Hmm.
It is all about giving the right diagnosis and decreasing the actual cost to the patient, which would come over a period of time of a wrong diagnosis or not being diagnosed. So I think cost, by just saying cost issue, we are not highlighting the fact that we are not diagnosing a lot of people. So that's very important. Uh, this is by Nagesh from Mumbai. How do you troubleshoot common issues with radial EBUS equipment, such as probe malfunction or image degradation? Samir, you want to answer that? Probe malfunction. How do you handle this?
Give a SOS call to Olympus people. Unless I have another in my spare.
Right.
I don't know how to answer that.
Mm.
Probe malfunction is,
I
I mean, if I have a spare one, yes, this
Hmm.
I'll put in a spare one. But if I have only one, then I think abandon the procedure. That's all I can do.
So the answer can be given, sir. Dr. Vijay, you said after 400 biopsies, you changed the probe. So what was the problem that you had when you were doing the 400th biopsy?
No, we lost the image quality. Probe gone. Right. Suddenly probe gone. Okay.
Malfunction.
And we realized that it is not functioning, and then it was not rotating. So in such scenario, what we have, yes, having one more. Generally, we don't keep additional probe, radial EBUS probe.
Nobody keeps, right?
No one keeps, because the probe itself would cost roughly around 4 lakhs. Yes, and thankfully the probe driver unit still functions. So that is another 6 lakhs. So this is very unusual scenario where probe malfunction and technicians generally, okay, they are able to once they hook the entire unit properly, it should able to deliver the good quality image.
I just want to add one thing, Vijay.
Yeah,
It does happen that in the probe, the ultrasound part loses the tip.
true.
It does happen. It is no longer as close to the tip as possible. Huh? So it loses that. So that is one thing which comes up, and that when you are doing procedures, you can make up adjustment for that.
Right.
Right. So it loses the tip. the ultrasound part comes little down. So the upper part is loose now. So that adjustment has to be taken. So that's a little malfunction that comes, but then you can adjust the length accordingly of the all the instruments, right? Uh,
Yes,
what
sir.
are the essential components of radial EBUS system? How do they contribute to success of procedure? I think we have all answered this thing that every point and every step of doing radial EBUS is very important, right from selection of patient to properly aligning the instruments to identifying and doing the procedure. So every step is very important. This has been multiple times highlighted. What are the optimal patient positions? A good question. What are the optimal patient positions and bronchoscope insertion techniques for radial EBUS procedure? Uh, Ganapriya, you like to answer this to Mahesh from Delhi?
We, we normally do the procedure with the patient in the supine position only. And
Correct.
through an eye gel, we give anesthesia, total anesthesia, and then do. And if you're using a fluoro and you're not able to localize a lesion, then maybe you can rotate the OT bed and change the position with the side up and all that. And or if there is a bleeding, again, you can change the position of the patient, like putting the patient on the bleeding side on the tilting the patient towards the bleeding side. So um, that's how we normally do. And other than that, yeah, we use the guide sheet when and wherever required. Not for all the cases, we do it
So the
less.
position of doing radial EBUS procedure is same as any other bronchoscopy procedure. That is one thing. But just want to know whether what is your preference? Do you do radial EBUS procedure through the nose if you're doing in a patient without eye gel or through the oral route?
Uh, Normally, we do through IGEL only because anticipating like an eccentric lesion and probably a cryo also, and fluoro where you want the patient to be still. So we do give under, do under total anesthesia. So it's mostly through IGEL.
Nagarjun, have you been doing it through the nose or mouth if you're not doing the eye gel?
Sir, if it's a smaller nodule, we would always prefer a deep sedation bar
Deep
GA with an
sedation.
IGEL. But if you want to do red libus for a large lesion where you're doing in a conscious person, it doesn't matter how you pass the bronchoscope. As long as your scope is there through the nose or the mouth, if you are there, that's okay for me. But for smaller lesions, I would not prefer a spontaneously breathing patient at all. I would want a person to be under deep sedation or GA and an IGEL or an ET tube.
Right. So for all practical purposes, radial EBUS procedure is done through the oral route because most of the time we are using the airway. Right. Now this is by Suresh from Pune. How do you navigate the airways and identify target lesions using radial EBUS? I think we have answered this thing. Doing the bronchoscopy is same as any other procedure. You reach till the very close to the lesion as possible, anchor your bronchoscope over there, and then use your radial levers
Navigate further.
one by one through each subsegments and identify the lesion, right, Suresh? Now this is from Thane. Discussion about fresh perspectives and value takeaway. That's very good comment from Jay from Thane. What are the key steps for successful lymph node sampling and tissue acquisition using radial levers? We are not sampling lymph nodes anymore with the help of radial levers, so I do not know how to answer this. How do you optimize image quality and adjust settings during radial EBUS procedures? Uh, this is from Ashish from Jaipur. Samir, do you really make any changes in the image settings when you're doing radial EBUS?
Not really, sir. I mean, I never faced this kind of a problem, to be very frank. So, whatever is the default setting has yielded us results.
Yes, so there is a default setting where 20 megahertz frequency is used, and we are using that. So we don't have to do like in linear EBUS, we can increase or decrease the depth or gain. Over here, we do not change any settings. What are the common complications associated with radial EBUS procedure, and how can we prevent and manage them? I think Dr. Aditya has already said this, Ajit. but I would still request him to just complete this answer.
So again, to manage the complications, to be aware of the complications, you need to have a proper checklist for before you put the patient for a bronchoscopy. Basic FOB checklist everybody should have, and the coagulation profile, the cardiac profile, and the renal profile, everything you should have in hand before you start a procedure, and then you be ready for a pneumothorax or a bleeding that may happen during your procedure. If you're doing a cryoprobe of a peripheral lesion or a mid-airway lesion, you may encounter bleeding. Of a peripheral lesion, you may encounter pneumothorax, and you may need to put an ICD on spot if the patient desaturates. Hypoxemia can be managed by supplementing oxygen, and infection, if the patient suffers post bronchoscopy, it can be managed by antibiotics. So these are the basic complications which can occur, same as a bronchoscopy, and we need to prevent those complications. We need to follow a proper procedure. The checklist should be done, and this checklist should be duly checked by the doctor who is going to do, and the technician also who is going to take the patient in before your presence. So that is the
Right.
only way you can prevent the complications.
Right. So proper patient selection, having the right investigations and knowing whether the patient has any increased chance of bleeding or not and what. So that's very important. And during the procedure, you should not be in a hurry.
Correct.
You should be doing it with a calm head, slowly taking care of each and every step. And whenever there is a bleeding, do not panic. Just be there. Most of the bleeding which happens through this will stop, and you will be
Eventually.
in most of the times you will be able to take another biopsy, right? So how do you troubleshoot difficulties with probe insertion, navigation, and image acquisition during radial EBUS procedures? Sujit, he's from Thane. So we have answered this thing in previous questions also and in our discussions also. So troubleshooting can be handled if you are very thorough with the procedure and every step, and you can anticipate what can go wrong and what can go right. What are some expert tips for improving radial EBUS procedure efficacy and reducing the complications? Kamal from Solapur wants to know this, and I would bring in Vijay to this. Vijay,
Uh,
improve his radial procedure efficacy.
So we have discussed very thoroughly, Dr. Ujjwal, as time is also, really, 10:45.
Now we are
So
just about to
I,
finish
I
this.
request he should go through the entire, presentation one more time. But at the same time, okay, whenever this point I think we have not covered. Whenever you are as a beginner, don't try to shoot at the small lesions. Don't hunt for 1 centimeter, 1.4 centimeter lesions. Please select the cases. Start with 3 centimeters, 4 centimeters kind of lesions, and then do use it for segmental consolidation, subsegmental patchy consolidations kind of thing, which is roughly around 3 to 4 centimeters, so that it will increase the confidence of you before going for hunting for 2 centimeters or less than 3 centimeter lesions.
Thank you, Vijay. Sorry for skipping some lesions, but I found some questions, but I found a very good question for Nagarjuna. What are the future potential applications of radial EBUS in lung cancer diagnosis and staging?
I think
Future,
the future is going to be ablation. The nodule
right,
ablation,
right.
the future, and there's a lot of progress being done. In India, we don't have access to it, but we are hoping that we will get radiofrequency ablation probably next year. But that would be only for a very small subset of people. So the whole concept of diagnose, stage, and treat in the same setting would be a dream come true for most of us. But that is only the future, I would say.
Yes, yes. In therapeutics, if this can come, then this could be really game changer, especially in patients who are having small metastatic lesions, where we can handle them. So this has been a very excellent discussion and a panel discussion with all of you. Thank you very much for being with me till late night. I just want to give you a message. There have been 230 live listings for this webinar, so it's wonderful. So this is a very successful
Sir,
It's
thing that
2000.
sorry, 2130. 2000. Sorry.
So we should also thank
2130.
the audience
So it's
for
all
staying up.
Yes.
thanks to Dr. Amita, Dr. Mehul, and IAB, who has outreached so many people.
Yes,
And
yes,
wonderful
yes, yes.
moderation by Dr. Ujjwal, sir. Brilliant moderation.
Thank you very much, Samir. Thank you very much. Nice meeting everybody. And I want to thank IAB for such an excellent work that they are doing in educating people when they are sitting in their home. This is wonderful. They're wonderful. Their reach is excellent. Thank you, IAB.
Uh, I would like to thank all our participants, to all 2,132 of them beyond your two for listening to the lecture. I would like to start by thanking Dr. Nitin to hear you, and all the panelists of this webinar, Dr. Samir sir, Vijay Boss, and our young Santa Claus, Dr. Aditya, and Dr. Ganapriya. And the captain of the ship, Dr. Ujjwal sir, I mean, you were summarizing things very well. It is, I mean, even I was waiting to hear the answers of the questions which are happening. So thank you, sir, for teaching us. And I would like to thank our academic partners again, Olympus and Mankind, specifically Mr. Nitin. And thank you all for staying up so late. An excellent presentation, and it shows the numbers are mind-boggling. And have a good one. I'll see you in the next one. Thank you.
Thank you so
Good
Thank
night,
you
much.
very
everyone.
much.
Thank
Good
you very
night.
much. Good night.
Good night. Bye.
Bye.
Thank you, everybody.
Thank you.
This goodbye.